this is a question for Allan. So is it safe to assume that, sorry. So it's probably safe to assume that females, X chromosome linked, will not have loss of functions, meaning you haven't found any because none of them, show any cases of any deficits, and that's why they don't come to the clinic. That would be my best guess.
How does this? It works. Okay. Yeah, we have found. The question was not because we haven't found anything. It's because we have found some. We don't just know. I don't know whether they're disease causing or whether they're just there and we need to find something else. It could be that they're disease causing because one of these patients was in fact inactivated in their X chromosomes towards the affected variants, but doing that is difficult to interpret, and so I'm just still very, very confused.
So what about the genetic backgrounds of all the women or the mothers that you said are completely healthy, but they did have the males in which they had loss of function? What about there? Did you kind of, dig deeper into the genetic backgrounds of the mothers? Could you find any indication of something?
No, we didn't. Like normally, a lot of these we haven't seen the families themselves. They've been sort of like, for example, Eleni, you see the families and then your group types in the clinical data, you share them, or I can sometimes get in contact with the families and then I interview them. And of course, I don't get a sense of any problems and ask in depth, but often I never get to meet the families. But even if you get to meet the families, ideally you sort of want to test them, wouldn't you? Like, because you could have some very minor problems and you would be borderline something and you wouldn't pick that up within an interview. So of course, there is like a gray area that we're not seeing because we're using all our energy on the kids and not so much exactly on the carrying mothers. But the question is right, yeah.
Hi. Maybe you can check the X chromosome inactivation status of the mothers, because I used to work with and investigate X chromosome inactivation in autoimmune diseases, and usually there was more females than males, and they were over 80%. They had extreme X chromosome inactivation, so maybe it's the case. So they don't show it, but because they have the X chromosome inactivated in the mothers, if it's inherited from them, it's just an easy thing to do with checking the blood.
Yes. Currently, we don't have IRB approval to collect the blood from the mothers, but that would certainly be something that you would want to do, is to sort of get that sampled and tested. But it is a lot of carrying mothers that are apparently healthy. So it's really difficult. It is a big task, isn't it? Both to interview and test all these apparently healthy mothers to maybe catch something, and then to get their blood to see if their X inactivation is towards the healthy allele so it is a big task, but yeah, that's ideally maybe something one has to do, or we have to do. So we haven't done it yet.
Yeah, I have a question to France. It was nice to see that there are so many projects going on in Lyon, and I have a question to the clinical trial that you are intending to perform. Is it already a fixed trial, or is there a possibility to include other partners, other countries? Because I think after the successful trial that had been going on here in Barcelona, a second or a follow-up trial should be a large trial, including several places. And I fear that 40 patients or 45 patients have only a limited benefit over what we already know. So therefore, if there would be more partners possible in there, I think there would be several interested.
It is a fixed trial. The protocol has been approved in statistical basis because we put the number of patients sufficient to have results with N of 1 statistical methods. And it is a heavy protocol because you should see the patient 5 times, and each time you have hospitalization, doing a lot of things repeatedly. And it is, they will have periods of 3 months, two times placebo, 2 times Elserin. I think it's the first one maybe versus placebo. So that's the interesting part. But it's a first study. Then other studies, it would be also for safety and things like this. It's really we would like to try to do something really very regulated, and then try to broaden it if we can manage to find the biomarker also with TMS and EG that could be used further. But for this one, yes, it's only these 3 sites.
Okay. I just want to let you know that there are several collaborative groups that would be interested to join and to help to increase the power.
That's wonderful. That's wonderful. We keep it in mind, and it would be great to have further.
What can be done is to look for funding for other. I mean, even if this goes on, to look for additional funding from the European Union and open the centers, even if they are later, doesn't matter. I mean, it takes so much time usually.
Yes, have the first results and then follow with more fine-tuned study. Thank you.
Okay, I have a question back to the GRIA-3, and just based on the Broad and Stanley Center's data, where they got bigger and bigger data sets looking at schizophrenia, and the fact that GRIA-3 and GRIN-2A, null, early truncations pop up. What are your impressions based on the work that you've done vis-a-vis neurodevelopmental disorders versus schizophrenia symptoms?
That's a good question. When that study came out, I think that was last year or year before, where they found out that GRIA-3 was one of like the top genes involved in that. Really got us interested. So we actually put that within our questionnaires, but we have 0 families reporting back that their kids have a diagnosis of schizophrenia. And I recently had or heard a talk by one of the co-authors of that Nature paper, and the way my take home was from it that the variants they had picked up was somatic variants. These were not germline variants. So I'm not sure that we can just say if you have a germline variant that necessarily maybe you do have an increased risk of schizophrenia over lifetime, and maybe some of these kids may in fact have it, but it's impossible for us to tell because they're so handicapped. But just to say that in that Nature paper, I think that the variants were detected somatic and not germline. But I mean, it's certainly something we need to look for, because Johannes, you found out that there was an increased risk in GRINs for schizophrenic disorder. Isn't that right? Yeah. So.
Hi, over here. Hi, I have 2 questions, sorry, for our friend from Denmark first. We are from GRI UK, so we've got a number of families with GRIA-2 in the UK. And is your work, can they contact you, join you, participate in any future? Okay, even though we're outside of the Brexit.
Yes. And we collaborate very closely with the people like Ian Coombs, who's here already. He's testing a lot of the GRIA-2 variants that we have. So definitely. So yes.
Okay, great. They talk a lot often of movement disorders. So I think they'd be interested to know what you know about that. And the second one is also kind of related to Brexit, unfortunately. In terms of the ERN, we have a number of families that have really difficult to treat epilepsy, for which they struggle to get the right advice in the UK. And it's often a postcode lottery of where you live. And sometimes you're in a small local hospital and they don't have the advice. Like, do you have any advice for them in terms of how we can get their doctors to access some of this wider knowledge on difficult to treat epilepsies where GRIN is a causal factor?
I mean, if I can find out, I can tell you who were the centers. I mean, they are public. They are even on the website as supporting partners that were members of Epicare before the Brexit, including Gosh, Birmingham, the Oxford. I don't remember them all, but now are they specialized in GRIN specifically? I don't know because I didn't look for it, but I can check. If it helps, because I suppose the question is, can the patients find something in the UK rather than going around Europe?
Yeah, yeah,
So
absolutely.
I can check. I mean, it's easy. I know sufficiently well my child neurology colleagues in the UK that I can find out quite rapidly.
Okay, great.
If
Thank you.
needed.
Hi, this is a question for Allan. It's maybe a bit technical, but when you look at your loss and gain of function in the oocyte, what are you co-expressing the mutant GRIA3 with?
UA2, wild type.
Just that, because I was wondering whether or not some of the
The lab was trying to the expert from Israel, like the lab that I did my postdoc in, where they were trying to set up that S1 S2 thing, but they didn't succeed at the time when I was there. So we can only do like start with the homomeres and then express it.
Because I was also wondering because maybe we can talk later, but a lot of the AMPA receptors confounded because of desensitization of the receptor. So you might be missing sort of mechanism by which the mutation is causing loss or gain of function. And I think that going down the route of looking at iPSCs and being able to identify what the particular synaptic receptors are is definitely a route to go.
Hello? Oh, yeah. This is kind of going on the back a bit of what I guess Johannes was just saying as well, and to all three of you at the front. I would urge you to consider the next time you design an L-serine trial to consider putting in some GRIA loss of function patients. Because when I was here last year, I talked about the idea, because they're so linked, if you can have a drug that affects AMPA receptors, it maybe has a slightly better than average chance of improving certain NMDA symptoms and vice versa. And certainly, anecdotally, at least, there are a couple of really encouraging sounding cases where patients with GRIA loss of function have been tried on L-serine, and they seem to have, really clear gains in their kind of behavior, in their development. But it's completely sporadic at the moment, and there's been no trials at all. Because I also think that the basic science behind why L-serine is helping GRIN is it's not quite there. I mean, the theory is fine, but whether that is actually what it's doing, we don't know for sure. It could be L-serine doing something completely different, and it just so happens it's improving the symptoms. Or maybe D-serine is not even acting through NMDA receptors. It could be acting through the delta subunit and changing some, just generally boosting glutamatergic drive. And so there's certain reasons why you might believe it could be possible to help with the loss of function GRIAs as well. And at the moment, they have nothing. There's no PAMs. There's no anything you can directly treat the GRIA receptors with. And so if there could be some proper clinical data behind using L-serine, that would be really valuable. And I think there is already a couple of encouraging signs that it could be something worth building into a future trial. Sorry, there was no question mark there. I'm just
Yeah. Yeah, but I agree with you. I can only say that Ian and I have talked about this before. There are some anecdotal patients, like for gain of function, it's perampanel, which is blocker, a specific one. It works very well. There's around a handful of patients with epilepsy having tried it, and they often become seizure-free, but there are some where it doesn't work. But if you have a loss of function, this is really not much I can prescribe for them. I've tried to advise to some patients worldwide, some in US, some in Denmark, some in Israel, to try Elserine, and at least 2 of them have been in contact with Ian and I and said it's really improved. Now the problem is, since it's not a clinical trial, I can only advise to do like a Vineland or EEG, but sometimes they don't even have access to that, you know. And often it's not placebo controlled. So at least to encourage you and to the Spanish group, if you're interested, I have an overview of the loss of functions. Like, it's a matter of, we can collaborate, send them to you if you have an ongoing trial for that. There is an urgent need from the families, at least, just to let you know. So.
I would like to comment on a couple of things. First of all, there is a clinical observation about neonatal hypertonia, which is really rare in genetic conditions. And we saw another patient with a gain of function GRIN1 mutation and extreme rigidity. It was really very impressive. And then there is a gene that is called ATAD1 that is related to AMPA receptor trafficking, which is also involved in neonatal hypertonia. So just as a differential diagnosis without hypereplexia, but neonatal hypertonia, which is dramatic, is very impressive. So just as a clinical hallmark, this is very, very interesting and very nice presentation. Thank you so much. Yeah.
It's really recognizable symptoms, and there aren't that many genetic disorders that have this hyperexia.
Yeah. And then regarding the Elserine, Elserine is an amazing molecule. Is a very small molecule, but with thousands of functions in the cell. And as a metabolic physician, what I can say is not only like the conversion of B-serine and then agonists of the NMDA receptors, but Elserine is a precursor of sphingolipids. It is involved in energy metabolism. It is also the precursor of glycine, and we have many other relations with serine hydroxymethyltransferase and the folate and the nucleotide pools. I mean, there is there are many pathways where serine is involved. And I totally agree that the effect and the positive effects that we see in patients may be due not only to this signaling function where when it is converted into D-serine, but other functions. So what we are conducting also metabolomic studies just to try to understand a little bit, but it's the power of metabolic treatments for non-classic inverters of metabolism, and that I think it's a very important pathway to explore.
Can I add something? In our placebo-controlled trial, the Austrian group, the laboratory, they will take the included patients and mutation by mutation, and they will try to see whether the Elserine has an effect in vitro also. So we will gain some experience from this kind of.
Well, we need to break. I'm sorry, and we can continue the conversations down there at the coffee break. Thank you very much to our 3 speakers.